Hello, everyone, and thanks for joining from Chaos to Clarity, HCC 2026 and RADV CMS's New Era Risk Adjustment webinar. My name is Katia Arteaga, and I'm a Product Marketing Manager at IMO Health and will be serving as a moderator for today's fireside chat. Before we get started, a few housekeeping items for you. First off, this webinar is being recorded and will be sent to you later in the week via email. If you have any questions throughout the webinar, put them in the question section on the Zoom webinar console. And at the end of the discussion, we will have time for a Q&A, so take advantage of our experts being on the line. Today, I am thrilled to announce our experts on this topic from IMO Health, June Bronnert, VP of Global Clinical Services, and David Green, Business Development Executive. As many of you know, CMS is set to fully implement the V28 HCC model in 2026. Alongside this, the expansion of risk adjustment data validation audits, also known as RADV, is significantly rising the stakes for both payers and providers. These changes represent a major shift in how risk adjustment is calculated and reviewed by CMS, with far-reaching implications for both clinical documentation, compliance, and as well as reimbursement. While this transition may feel chaotic, our goal today is to bring clarity through our expert insights and discussion. So June, to start off, can you walk us through how HCCs tie into RADV and give us a bit of context of how we got where we are today?
Sure. Yeah, no, it's great. And before we look forward, let's take a look back throughout because how the HCC model is a predictive risk model. And as we'll talk more around the RADV is around the audits focused on the payments that come from this model. And so starting with on the left-hand side of the screen, just to kind of reorient and go through a bit of the history on the model for CMS for HCCs, starting with payment year of 2018. And as this model is predictive, the actual dates of service happen in a calendar year prior. And so you can see here in 2018, for those dates of service 2017, the model that CMS was using for HCCs for reimbursement was what was known as version 22, and they were paying 100% from this. And this model, some of the critiques along with which have happened throughout other CMS payment models are for individuals who have a high number of HCCs, is the model really reflective of those expenditures for the care that those patients need? Along with around this time, as you'll see, when we start moving to a different model, was also the 21st Century Cures Act that outlined certain areas that CMS had to account for in these programs, as well as the numbers of HCCs. So that drove a newer model known as version 24. And so while CMS has and uses this information to predict the expenditures, when these models shift, there's typically a phase-in period. And that's what's shown here on the slide of how the move from version 22 to version 24 was phased in for providers, payers to manage these different models because there were different rules in addition to just in general different ICD codes that were part of these models. So we had the timeline from the starting in the payment year of 2019 to payment year 2022, the full phase-in or the partial phase-in full effect in 2022. And version 24 was the 100% payment for a couple years, and then along came version 28. And this is where, as starting with the phased-in approach, you can see even how the phase-in, it went faster than version 22 to version 24, but again, it was a phased-in approach. But version 28 is now for payment year 2026, the 100% of payments that organizations will be receiving under this newer model. So, and why this is important is because as the RADV audits occur, they're going to occur for these different payment years where there's different versions and different models that we'll get into a little bit more later. So,
thanks so much. Or
a
June,
little bit
sorry, I didn't mean to cut you off.
no, it's a little bit of backwards as we look forward to some of the changes, as we'll see on the next slide, around for the payment year 2026. Really, there's a lot of detail because, again, this program is predictive and there's various factors. But for our purposes of today, where we want to center on is around those HCC changes. And so, as you can see, what was finalized was 100% of what is called the 2024 risk adjustment model, but it's the version 28, which is typically how is known and what's reflected. So those calculations for risk scores will be 100% version 28. And just a highlight, a refresh on what is some of the major changes with version 28, you can see here on the slide as well. The model was built upon ICD-10-CM codes for the prediction. And so the goal was to improve the predictability of the model using ICD-10-CM codes. Prior to version 28, while we were reporting ICD-10-CM codes throughout the process, the underlying principles of prediction were based upon ICD-9-CM codes, and that changed. And so part of that change was the reclassified conditions, the expanded number of HCCs, but yet also there were reductions in actual codes, ICD codes, from participating in these models. So that, I think, is some of the biggest changes when it comes to version 28 that from providers' perspective, payers' perspective in managing this newer model. And just another highlight was, again, because the model is predictive, the data that is used prior to version or for 2026 or version 28 was now updated to more actual expenditure data from 2018 and 2019. So that was leveraged to help determine the predictive amounts and the different factors for the HCC model, all with the goal of having the higher payments available to plans to support the beneficiaries that are, and to follow that model of the higher risk beneficiaries require care and everyone is compensated for that required care. So some highlights.
I appreciate that, June. So with all these changes in mind and also the recent expansion of RADV audits, how should payers and providers be navigating what's coming? So David, let's start with you. What strategies are you currently seeing with payers right now?
It's a great question. And in my conversations with payers, it's kind of been all over the place a little bit. And I think that's reflective of kind of the reactionary nature of that we have to big changes like this. So some health plans are going to be more able from a resource perspective to do different things. Others, without those resources, are going to have to approach it differently and maybe outsource some things that others might keep in. But essentially, they have to rethink almost from square one how they're approaching Medicare Advantage risk adjustment. And I say that because it's not just, the fact that you've got to, make sure that you have agreement between the diagnosis code and the clinical evidence in the RADV file. Of course you do. But you're also going to have to now, with the new rules that have been announced, be able to go back in time and justify the files that you've submitted in prior years, going back to 2028. So 2017 calendar year dates of service submitted in 2018, as June just mentioned. Those are particularly problematic because as I think everybody knows, the world has changed a lot since 2018. There's the tools, the versions of hierarchical condition categories have changed. Diagnosis codes have been updated, they've come and gone. All of that has to be managed appropriately. The tools and the way that everybody thought about risk adjustment in 2018 is significantly different than it is today. The resources and experience that people have, so it's really overwhelming, I think, for some organizations, Katia, that they're having to deal with. And I don't think they've really kind of figured out, what the solutions are necessarily yet. I think there's some best practices that are emerging. And it really kind of takes two different paths. One, they want to make sure they can address these prior year audits in a way that puts them in the best position to come through those audits positively. And so that requires internal resources and probably external partners to review those in ways that allow them to get ahead of those audits. There's a big difference between being reactionary to an audit and being proactive. If you go into an audit and you're able to say to CMS, you know what, 2018, when we submitted that, we've looked at it and we've got a few things we'd like to withdraw from that file, that actually is not nearly as punitive and is not extrapolated the same way as if you're caught essentially by CMS and they say, no, there's no agreement here between these records that we're reviewing. That's when the extrapolation happens, and that's when it really can be punitive from a financial perspective, because they take, if you have 10% error rate and it means this much to the sample group, the 200 records that they're reviewing, that is extrapolated across the whole member population for Medicare Advantage that you have for that time period. And that's why those are so hurtful in terms of from a revenue perspective. I think the other thing, so you have to have a plan for those prior year audits. And I think that's something that's still evolving. Many organizations don't have the manpower to put the eyeballs on those records adequately. So it's going to require probably a partner approach to making sure that you're fully prepared for those and can get ahead of those in ways that are going to help your organization. The second thing that organizations can do moving forward in 2026 and beyond is to have a complete, I think it's a complete rethinking of their risk adjustment programs. And what I mean by that is, it doesn't mean you have to radically change everything you do, but I think you have to change your preparedness, because you know that you're going to get audited, period, just full stop. You know that. They've said it, and I have every reason to think that they're not kidding here. So with that in mind, you have to be prepared, and you have to get ahead of things. So the more you know earlier, the better you're able to prepare your submission file for that calendar year, in this case, 2026 coming up. People are going to, resources are going to become a real premium. So coders especially are going to become a premium. They already are, but they're going to become even more of a premium, because folks are going to want to get ahead of this and do, I think, what's a best practice, which is looking at mock audits throughout the year, probably at least a couple times throughout the year, so that you can kind of better understand in a more granular way if you have vulnerabilities to the data sets that you're building for that calendar year, for that dates of service calendar year. If you do that, along with other steps like provider education and internal data analysis, perhaps with a partner, perhaps not, then I think you're just in a different place in terms of being ready for those. If you can correct issues before you submit them, obviously you're going to have a cleaner file. You're going to have less chance of problems during an audit, and you're going to get in a rhythm that's going to be very helpful for your organization overall in terms of how you're scoring internally your own CMS file, and in terms of the expectations that sets throughout your organization, because so much is dependent upon the accuracy of those files and the reimbursement that comes with those from a predictability point of view and so forth. So I think it's going to also put pressure on the relationships between payers and providers. These relationships are so important for obvious reasons, and especially in this sense, because there's obviously a dependency on the provider organizations to be accurate in how they code and how they document. And this is really kind of shining a bright light on it. If it's not already bright enough, it's even brighter now. So I think the working relationship between payers and providers has got to improve. I think there's got to be better data sharing. There has to be better cooperation between organizations. Ultimately, the way we view it, and we're very much at IMO a provider-centric organization, we put these types of issues in the context of patient care and how outcomes are dependent upon good documentation and good coding. That simply improves the whole care process. Putting risk adjustment aside, I know we're talking about RADV, but in an overall sense, that's how it should be communicated. So I think payers can help with that process in terms of communicating in those terms, in those ways. So that it's not just all about risk adjustment. It's not all about RADV and RAF scores and that sort of thing, HCC capture. Those are all important, of course. But in the context of patient care, it really needs to be about the patient. It needs to be about how this care can be better served with better documentation and better HCC capture. I think that's the way it has to be ultimately communicated.
Yeah, no, that definitely makes sense. Thank you so much for that, David. So quick question on like collaboration with payers and providers. So I know part of the process to validate some of the risk scores that payers have is looking at medical records. And I know there's sometimes some efficiencies with medical record retrievals. Can you kind of talk about what strategies you've seen to help providers make sure they're providing the right data to their payer partners?
Yeah, this is really kind of a point of contention in many ways. Medical record retrieval for many years has been spotty, sporadic, untimely, and the data quality has just been all over the place. And all of that has really dramatic impacts downstream to getting an accurate CMS file prepared, a RADV file prepared. So it's really a challenge. There's trust issues that come into play as well, and data ownership issues. All of those are real, and they have to be navigated thoughtfully by both parties, really, by payers and providers. Payers have a need, a business requirement, really, for getting this data and incorporating it into their processes, their workflows for risk adjustment and for preparing their CMS file. But providers also are protective of that data, and they should be. So payers have a process where they use different vendors to gather this data up. These processes can vary between being electronic and being pretty much seamless in some cases to being manual, where people still go into doctors' offices and make copies of records and then fax those to where they need to go. I mean, it really runs the full spectrum of different techniques there. I think the industry is really ready for something that's more seamless and especially more protective of the interests of the data integrity on the provider side. Providers ultimately have a yes or no to data requests coming into their organizations, as they should. And so they necessarily want to provide that information only to trusted parties that they know and can have confidence in, that are going to take care of that data the way it should be from a HIPAA perspective, and then it's not going to have ulterior use cases that approve of.
Yeah.
So I think that's where different partners can come in who have established relationships there. But it's not just about getting the data, it's about getting it on time. It's about getting it completely, because if there's missing data or data that's not clear and can't be used, that almost makes it worthless. So I think both of those things are extremely important, and the industry, I think, clearly needs some options that can meet those requirements.
Yeah, just to add to that, I completely agree. I mean, there's just even some fundamentals, and especially with the audits around 2018 and 2019, David, you're spot on about how our view of the world has changed. And there were requirements from the HCCs of the face-to-face visits. And obviously, after COVID and during COVID, that was a shift. So, when you're looking at gathering the records and having that communication and trusted relationship between the payer and provider is, having those appropriate records. And then are they even signed by the provider who provided that face-to-face encounter is also another key factor to having not, like you said, not just the documentation, but the appropriate documentation.
Yeah, and it's exacerbated even further than that, June, because typically a well-documented record includes several medical records for that particular patient during the year. So it's not a one and done usually. It's in that those different data points are really important because it shows the difference in care that's happened during the course of the year. And if different inferences can be made in terms of care, it might be that there's diagnoses that have not been documented that are present in the clinical evidence because of the documentation that's there, because of the record. And so those things need some time to be resolved. If that's the case, then the provider needs to know that, hey, there might be some opportunities here for being more specific about a particular diagnosis, or maybe even adding another diagnosis if the evidence is there. But the provider is ultimately the arbiter of those, the ones who have to make that decision and have to make those calls with the appropriate evidence. And it's very appropriate for payers to come back and say, hey, you know what? What about this or that? Do those things make sense in your view, doctor? And if they do, then that's great. If not, then they don't. So, but that cycle, that communication cycle takes a little bit of time. And so that's why you want to make sure you got the data in and you can evaluate it appropriately to see if corrections or additions or subtractions need to be made.
Right, because there's, like, my understanding as well is there's strict time frames to respond to audits to ensure the documentation is there. And so, just even some practical implications is the staffing and resources to facilitate that. So yeah, having that two-way flow of communication and documentation just seems vital in today's world.
And you also bring up a good point with like the constraints with staffing and resources. And in the age of AI, like how do we see AI tying into RADV? And I'm also gonna try and launch a poll question to our audience members because I am curious how our audience members also see AI in the RADV workflow.
Yeah, it's a great question. I think, and there's a couple of different ways to answer it. So AI is everybody. You can't talk about risk adjustment without somebody saying AI. At least if not the first sentence, the second sentence, it'll come in there, and it's for good reason. I mean, AI is a great tool when tuned correctly and appropriately, and when fueled with the right infrastructure. It can be a great tool and a great partner in creating efficiency in this process. But it was Many health plans use AI in various forms already. Usually it's in a retrospective way, but it doesn't have to be. They get data, they look at it through AI, coders look at it, and then they come back around to providers. That's really, in my view, one of the most inefficient ways to use it. But it's kind of how we've evolved. And I think more efficient ways to use AI are at the point of care when you can have a smart AI system evaluate data, provide immediate feedback either directly to the provider or to the payer organization, and then maybe back to the provider on occasions where you may not have agreement between the diagnosis and clinical record. You may not have complete information, and that might raise some flags. But also during the review process, during the audit process, I think there's certainly room for AI to assist in the process there for a payer. Many, like I mentioned before, many organizations don't have the resources to really kind of get into a previously submitted file, RADV file, and to really look at it and see where their vulnerabilities are. AI can help with that. It can point out those things so that the limited resources you do have can be focused on where you may have vulnerabilities and might need to make a change, either add, subtract, or delete, perhaps. So I think those are all kind of situations where AI can be a positive add. And I think if you're not using AI on the payer side to get your files ready, you're missing out, because it also should be part of your mock RADV audits during the year as well, for the same reasons, to help you realize where you have vulnerabilities. Is it with specific health systems, specific providers perhaps, or specific HCC codes? You need to know where you're kind of vulnerable and where you might have to shore things up. And it only makes sense because these are really powerful tools, as everybody knows, and it should be no surprise to anybody that CMS is using AI as well. So as they're bringing forth their audits, they're doing it with the 2,000 coders that they have employed and looking at the 200 records, but they're running it through their AI algorithms to find out where there might be vulnerabilities from their perspective. So it makes sense to have equal tools, if you will, on both sides to create an even playing field.
Yeah, no, that definitely makes sense. And I know we're coming up on time. I want to make sure we talk about how RADVs impact providers. So David, just to wrap up RADV for payers, what are practical steps right now that payers can take to protect their revenue and reduce any risk at the moment?
Yeah, I think this is where everybody kind of ultimately winds up when they're thinking about these changes is, what does it mean financially, or what could it mean financially? And it can be pretty devastating. So I think there's a lot that can be done there. I mentioned a couple of things already in terms of what can be done to help with the look back audits in 2018 year and moving forward. And perhaps what can be done moving forward as well. So in terms of moving forward, the mock audits are helpful, but I think it's about creating better communication with your provider partners, your health system partners. This has got to be a focus. Everybody's on the top of everybody's priority list. There simply is a real need for providers to know more than what's contained in their EHR. To the extent you can get them information to help with their documentation, their awareness of situations that happened outside their purview and may not be recorded in their record, it's just going to help them provide better care and make better care decisions. But you have to do that in the context of the clinical encounter. And you have to do that in ways that are extremely respectful of their time. You can't make them jump through hoops and, go outside of their workflow to get information that might be helpful. I think you have to have those in-office solutions, in EHR solutions. So I think being able to provide better communication, two-way communication, hopefully to your provider organizations is a good step and a necessary step. I know that that's spotty, especially when you get past the top, couple of EHR vendors. It becomes very spotty. So I think that's where a lot of work needs to be done, because ultimately, the better you can communicate with your providers, the better information they have, the better decisions they're going to make, the better documentation you're going to have, and consequently, the better results you're going to have from a RADV audit.
Yeah, no, that definitely makes sense. And this is actually a great segue to talk about how RADV impacts payer or providers. So June, would you be able to talk about how RADV impacts providers? And also, while June's talking, I do want to share the results. That way, folks on this call can see where their peers are with AI. So I'm going to share that real quick, but June, I'm going to hand it to you.
No, that would be great. Let's see the results, because as much as AI is in the payer space, it's also applicable in the provider space as well. So yeah, so it would impact both potentially to facilitate, because a lot of the similar themes that for payers are for providers as well. As far as resources, audits, doing your own audits to know where your potential vulnerabilities will be, and to continue to build the trusted communication partnership with the payer, because it really is, at the end of the day, about the patient and the appropriate care. So while there are a lot of areas that impact the providers, it is very much a partnership today, and in keeping up with that. So yeah, so there are certain conditions that are part of the model that we've seen moving from V24 to V28, then conditions that are no longer part of the model that still are being treated by providers. And it's still important to capture those conditions in the documentation to show that it is impactful to the patient overall, regardless of an HCC or not being part of that. So so that is some of when you think about the changes and the audits coming, providers have been audited in other ways for many years, from the Office of Inspector General, and now here's another audit, and there's some similar themes, but obviously there's differences because of they're unique to the program as that in this instance. So
yeah.
So I think there was a second part to your question again, Katia. So or
no,
I wanted to make sure that I captured that piece of it as we were looking at the AI, just jumped into that. But yeah, documentation is just central to preparations for, I would say, even beyond the audit. If you think about transitions of care and working with specialists in primary care, documentation is key of what is all the conditions that are happening with the patient. So
yeah, no, that definitely makes sense. And then in regards to the poll, it seems like our audience here is split between using AI, somewhat comfortable, not very comfortable. So it's still something new, which makes sense. There's still things we're trying to figure out with AI.
Complete sense. Yes, definitely. Yeah.
And to the point of documentation, I know with the provider side, the MEET framework helps make sure there's complete documentation. Can you elaborate on what providers should keep an eye out? Because that definitely helps with that payer-provider partnership.
Right. No, objective documentation, to be as detailed, specific as what is present with the patient, and having that documented objectively will support the MEET framework, because that is just an acronym around ensuring that conditions, that they are being evaluated, they are being treated, they are monitored. As most people realize, the HCC value and that diagnosis that has that HCC value has to be reevaluated every year. And one of the, over time, one of the things that I've heard routinely is, especially if it's a chronic condition like an amputation, of almost like, well, of course, that status didn't change. And while that is true, the point of capturing and reevaluating it is that condition, how is that chronic condition impacting the patient? What other types of resources are you providing to that patient? And so capturing that in documentation and having that not only at one visit but having that as part of your documentation whenever that patient returns, or if there's conditions along the lines that are impacting care, is objectively capturing that. And because that will show the resources that you are as a provider providing and using, and that can be communicated to the payer, to CMS, as well as ensuring that the patient's receiving the appropriate resources that they need along the way. So, so it's really about having that objective documentation that shows that these conditions impact the patient's health and care, and they're being addressed in that treatment, the evaluation, and monitoring of them.
Yeah, that definitely makes sense. And feel like at the point of care too, it's hard sometimes to document all the necessary details.
Yeah.
So do you know of any tools or mechanisms that providers can also keep in mind other than just the MEAT framework?
Sure. Yeah. No, it's a great question because specificity can be a broad word. And so saying that, I realize there's a lot of details with that. And from IMO Health's perspective, is we do provide tools to support that because we realize the demands that are on providers, and to try to have every rule around specificity top of mind, it is a challenge when there are tools to facilitate that and to support that. And so using IMO Health's precise problem terminology, there are areas where we start with and help refine to a more specific term that is known for that patient at that time along the way. So, and those are within typical provider workflows, because we realize, again, that is, the time and the efforts and the demands on physicians is limited.
Yeah, and I feel like another area that is a lot of demanding or just demands a lot of physicians is looking at the problem list.
Yes.
Yes,
Yeah.
I feel like a common theme is the problem list is messy. So any thoughts about like how the problem list can perhaps be used better at the point of care to help with potentially like capturing the right data for RADV or just even just improving patient outcomes?
Yeah, sure. No, there's probably hours we could spend focused on the problem list, but I won't. I'll hit some of the highlights. With that is yes. So the design of the problem list is going to be that table of content, or the table for providers to know this is the problem, and then here is how it is being managed, how it's being monitored, and treatment along the way. So that is the ideal state of that. Everyone knows there's lots of different challenges with that, and there are different solutions to support that. IMO Health has some too as well. So it is really designed to make that problem list what it was intended to be, to support providers in their workflows for these conditions that are impactful. So the information is presented at the right time, right patient for the right care, what problem lists are. And it's, again, the tools that are available are there to support that.
That's fair.
Yeah, just if I could add a little bit to
please
that.
do.
Please, yes.
June's spot on. We've done some research at IMO Health regarding problem lists and how well or not well EHRs do in providing an environment for problem lists to be used and kept up. You know, it's the bottom line is the results show that there's room for improvement there. And so that's one of the reasons that, you know, June, as you mentioned, we kind of got into that space at IMO Health, is to try and help provide a better workflow for providers during their problem list management. We know that problem lists are really kind of the roadmap to a provider's view of the patient's health. Here are the things that are most important to keep in mind as you spend those valuable moments with the patient in the exam room. Here's where to focus on, here's where to ask questions about, here's where to get more information on, and so forth. If you have an ugly or inaccurate, not updated problem list, it just creates a lot of unnecessary time at the head of the examination to get through the stuff that's really kind of shouldn't be there, or maybe it's expired or duplicative or all of the above. So having good hygiene with your problem list management creates actually the opportunity for a quicker and more efficient exam with the patient, which every provider out there is looking for ways to improve the efficiency of their day and the efficiency of their time, while not compromising anything in terms of quality and decision making. So having the problem list and having it available in context of the patient's visit is incredibly valuable.
And with having the problem list like accurate, I do know that we've also talked about that bidirectionality. So I do have a poll question for our audience. I am curious to know if like some of you would be interested in potentially using the problem list to allow the two-way communication between payers and providers. Problem lists historically are definitely more provider focused, but David, would you be able to elaborate a little bit more on how that could be a potential point to connect? And same with you, June. You too, feel free to answer that question.
Yeah, I think that the challenge has been historically that when problems or potential problems are shared from payers to providers, there hasn't been the best clinical evidence to back those up. Let's just put it that way. And so if you don't have that as a requirement up front, then everything else that comes down for review is going to be looked at with, well, you know, it may not be relevant because they didn't give me the good information, the backup information I needed before. So you really have to have a very strict criteria in terms of problems that you want to put in front of a provider if you're a payer, and meaning that you have to have that really solid clinical evidence for them to consider, that is going to resonate and that they're going to appreciate. So I think, you know, providers, and June knows this for more than I do, but providers respond to data. They respond to evidence. That's what they do. So if they're provided that with a suggestion, I think that's when it's going to be impactful. But that's the level that I think payers have to meet when they're providing suggestions or potential problems to providers.
Yeah, I would definitely echo and agree with that, as well as another aspect is it's another way to build that trust in the collaboration, as if the providers feel that that appropriate information is coming into them, then they are going to look at that through that lens of this, I can trust my collaboration with my payer, and building that those pieces and elements are really, really key.
Yeah.
Thank you both. Appreciate it. And I do also want to open it up to kind of understanding more what vulnerabilities both health systems and payers have with RADV. So,
Yeah.
June, I'm going to hand it to you.
Yeah, no, I think this is a great place. In general, there is information available around from RADV audits as well as other audits, and the results are published. And so areas that may be potential vulnerabilities based upon your own audit are in the diagnostic space. If you look at myocardial infarctions or heart attacks, there's very specific coding rules around when to code what is considered the acute versus when to code what is considered a history of this condition. So that is an area, and you can kind of see that theme also with the cerebral infarctions, the strokes, whether there's a residual or a not residual, around criteria that is being evaluated in a RADV audit for potential identification. And it's looking at across all care settings, especially with the stroke, as far as in the MIs, I believe too, is where there inpatient claims that occurred along with outpatient encounter visits that the payer received. And making decisions around, these areas and if they're supported in that documentation. So as you think about a payer and or provider, how common are these diagnoses to your patient population? And if they're common, are you auditing those to see it and know if you have a vulnerability or not? Continuing along embolisms, again, there's elements of, ongoing treatments as versus, if they're resolved or are they acute. Sepsis is another one. There was actually introduced fairly recently a new code around sepsis aftercare because the sepsis code was what was available, yet patients were being treated as that aftercare where the acute phase was over, but they were still requiring the monitoring, the antibiotics. So there's now actually a new ICD-10-CM code to support those types of situations. So keeping up with those coding changes is also key as you think about potential vulnerabilities, because as the codes change, the guidelines change from the coding rules. In these areas of diagnosis, you want to ensure that the appropriate code is being reported along the lines. So, and another larger general diagnostic area, again, is related to neoplasms, cancers, as well as because again, there's coding specific guidelines of, are they current condition? Are they a history? What type of treatment is occurring? So again, documenting all of those aspects of these conditions really is important because it's going to support the appropriate code assignment that is made. So that's from the diagnosis perspective. And generally from a documentation perspective, kind of hit on this earlier about ensuring the records are signed and signed by the provider who's providing that treatment, as well as having that evidence of, in general, the meet criteria of the monitoring, the assessments, the evaluations, the treatments, and being as specific as possible from there. So those are just some general areas for vulnerability from both sides, at least in my opinion. Now, how they're evaluated may take a little different form, and turn it over to see if David has any thoughts from the payer side.
Yeah, so I'm gonna kind of double click on the provider side first, if you don't mind, just because I think it's a point that needs to be made, that when we roll out our solutions to provider organizations, one of the things we'll do is called a data quality analysis. And that's a process whereby we'll take a year or 2 or 3 of their activity and look at the diagnosis specificity that they've been providing, so to try and create a contrast of how we can improve that going forward. So what we've found is that over a third of diagnoses are of the unspecified variety. So the E11.9, diabetes unspecified, for instance, extremely common. And it's a bit of a shock, I think, in some cases, where we'll provide that information back to those organizations to show them, here's what here's what your usage has been, here's how it's been working. And they are organizationally, they're vulnerable to revenue cycle impacts as a result of that, because those unspecified diagnoses, those 1/3 of all diagnoses that are unspecified, are really vulnerable to being prior auth or to being rejected in a claim sense. So as well as to create a feedback loop from their payer partners requesting more specificity, which is where we can help out quite a bit. So from a payer's perspective, certainly there's a need for improving that diagnosis specificity and completeness, quite frankly, too. So it might be that you can be more specific about a diagnosis, but there could be a diagnosis family that is kind of opened up as a result of that improved specificity, which is incredibly important in terms of documentation and completeness and reimbursement. So getting that information and getting it correct is very much a byproduct of a direct product, of exactly what, June, you were talking about here in terms of the provider organization. So just highlights the partnership and the acute need for communication back and forth between payers and providers. Not to beat the drum too much, but it's just a requirement in this new era that we're entering into. And so payer organizations need to really think hard about how they can achieve that in ways that foster and improve the relationships with their payer and with their provider partners, and look at it as an opportunity to move forward in ways that they haven't to this point.
Yeah, no, thank you for that, David and June. That was really helpful. I know we're almost at the top of the hour, so I do want to open it up for Q&A. So if anyone on the call has any questions, please type those questions in the Zoom box, Q&A box. But I see a question already. So June and David, one of you, what is the difference between RADV and OIG audits?
Yeah, I can start. It's great. They're both audits. They're both going to require documentation to support code assignments. However, the OIG is Office of Inspector General, and they audit a lot of variety of claims in the healthcare space, among other things, but in the healthcare space and a lot of other payment programs. And so the RADV is focused on the Medicare Advantage and those rules for that. David, did you want to add?
Yeah, I think an audit is an audit, and it certainly is painful either way. RADV is, just like you said, targeted on Medicare Advantage only. OIG is broader than that and can incorporate different populations beyond Medicare Advantage. They both require that you have good documentation. I think Medicare Advantage and the RADV is a little more specific in their scrutiny, in my understanding. But neither one is a really pleasant experience. And so it just behooves you to not only document well for your Medicare Advantage patients, but for all your patients that might come under audit susceptibility.
Oh, that makes sense.
I agree. Yeah.
There's another question, and I can answer this one. Are we going to get copies of the slides from today's presentation? We will send a recording, so you'll be able to access these insights later on, but not the slide deck. And then we'll move on to another question related back to the topic. How can payers and providers better align on documentation and data to avoid surprises during audits?
Yeah, it's definitely a great question. I mean, I think part of it is just starting, at least from a provider perspective, is starting a conversation with your payers and major payers, realizing there's resources around the audits. Have they received? I would suspect if they have, they would probably be reaching out to the provider, or high level, what are some of their plans related to this topic, to build that and look for those opportunities to have open dialogues because as David was saying, the environment has evolved and it's changed. And I think there's still some unknowns to be figured out between payers and providers, but having an open conversation, those dialogues, to me is the first step.
Yeah, I couldn't agree more. We've talked about, what's happened from 2018 to now. What we haven't talked about is where are we going to go from here? What is the future going to look like? And we're in version 28, version 30 is kind of going to come. There's going to be other requirements. I would venture to say that all of those new things that we don't even know about yet are going to require better payer and provider collaboration and communication going forward. So to the extent you can approach that from a patient care and patient outcomes perspective generally, and then as a result of that, yeah, we're going to be able to do better with risk adjustment and with RADV. I think you have to ground it in patient care and patient outcomes, and go from there as the case may be. But starting there is going to be a point of continuous agreement between the parties, and is going to create the foundation for better communication moving forward.
Yeah, and you maybe sparked a thought around. We know a lot of diagnoses, especially that impact payment, receive a lot of limelight for a variety of reasons. Yeah. But realistically, and there will be other versions and models. We've seen them happen pretty rapidly in the past few years. And so continuing to document all the conditions from that patient care is so key. I like to say that even if they're not part of a payment system today, they could be in the future. So, today's diagnosis may be an HCC in a few years. We don't know, but CMS needs the data in order to be able to run that data, to do all their predictive analytics, to evolve the program. So yes, grounded in that patient care is fundamental for a variety of reasons.
And then I have one more question. Is the process of RADV audit similar to a CMS audit?
Well, it is a CMS audit, to be clear. So CMS manages the RADV audits themselves. So I guess there could be other CMS audits as well that are not RADV. And those would be kind of governed by specific rules for that particular auditing population and that business. We focused on the RADV audits here because it's very top of mind for many organizations. So, but there are different types of audits there, and that would be probably another webinar.
Yeah, and just to add to that, the RADV audits, since they're focused in these areas, they do have their own rules around, like the submission requirements, the time frames, as well as just the identification of the beneficiaries that they're going to audit. And that's where, there are definitely very specific rules. And like you said, David, they're still CMS. They're just another form.
Yep.
So we are at the top of the hour, so we're going to go ahead and close out for today. We hope everyone here found the information in today's webinar useful. If you have any information regarding IMO Health, please contact sales@imohealth.com. And thank you everyone for attending. Have a great rest of your day.
Thank you.
Bye.
Thanks, everyone. Bye.